Dear friends, it's a pleasure today to share my presentation regarding the soft tissue management around dental implants. The first things that I want to underline is that when we speak about soft tissue management around dental implant, in literature there is no a clear definition because in most of the papers and in literature review we found the terms soft tissue augmentation procedure and we really don't understand which is the real purpose of this surgical technique. So first of all, I would like to come back a little bit with you with some anatomy concept, with some basic concept. And we define the supracrestal soft tissues as the tissues that can be measured from the mucosal margin to the bone crest. These are the supracrestal soft tissue, which are not attached to the implant supported reconstruction. Supracrestal soft tissue replace the old term biological width, that cannot be really used when we speak about implant, because when we speak about supracrestal soft tissue around implant, we don't have the tissues really attached to the implant supported restoration. We have the junctional epithelium like around teeth, but we don't have the connective tissue attachment because we have the connective tissue fibers that run parallel to the implant or to the abutment. And when we speak about the transmucosal path, we are speaking only about the inner aspect of the tissues that can be defined from the head of the implant to the mucosal margin, but from the inner aspect. These differences between transmucosal path and supracrestal soft tissue is really an important concept. And regarding our surgical procedure, we can basically divide surgical procedure into, from one side, we have the surgical techniques that aims to increase the keratinized tissue height. But what do we mean with keratinized tissue? Keratinized tissue, it's a vertical dimension that can be measured from the soft tissue marginal mucosa to the mucogingival line. This is clinically what we call keratinized tissue, and it is in relation to the position of the mucogingival line, which is different in every patient and which is genetically determined. When we speak about increase in soft tissue thickness, we speak about a completely different aspect because we are speaking about an horizontal dimension. We measure the soft tissue thickness from the external with a needle, for example, until we touch the implant, the hard surface of the implant supported restoration, and we measure the quantity of connective tissue that is comprised between the external and the internal epithelium. So two completely different measures. Vertical one is keratinized tissue and it represents a feature, an external feature of the soft tissue that cover the implant supported restoration, while soft tissue thickness represents the quantity of the connective tissue that we have between the external epithelium and the junctional epithelium. So when we speak about technique that aims to increase the keratinized tissue, we speak about the free gingival graft, which is the most predictable techniques to obtain this outcome. These outcomes means an increase in a stable band of keratinized tissue, which is the aim of this technique. Why do we want to increase keratinized tissue? Because we don't know exactly from the literature if we really need keratinized tissue to improve peri-implant health, but clinically, for sure, we know that if we want to improve the plaque control in our patient, it is always better to have a stable band of dense attached to the periosteum keratinized tissue, because that helps a lot to improve the oral hygiene procedure. So the aim of the technique that increases the keratinized tissue is to obtain this stable band of tissues to improve oral hygiene. So the indication of the keratinized tissue procedure is mainly on the posterior area. And the technique of choice is the free gingival graft. When we prepare the recipient bed for the free gingival graft, we have to prepare an area which is 6 mm wider than the implant width, and we have to prepare with a full split thickness incision in order to be able to completely remove all muscle insertion, because we want to create a periosteum area without any muscle insertion, to which we will adapt the free gingival graft. Once the flap, let's say, has been elevated, we can cut the remaining alveolar mucosa, and we suggest to fix the alveolar mucosa apically in order to obtain a better bleeding control and to stabilize the alveolar mucosa, avoiding any movement of the free gingival graft when the patient will start to chew or chat and will move the lip. So the receiving bed should be prepared with the blade parallel to the bone, with the so-called deep split thickness incision to remove all muscle insertion, to create at least 5-6 mm height of periosteum area, to which we will fix our connective tissue graft. The free gingival graft obviously will be harvested from the palate, and the thickness of the graft will be around 1.5 mm in order to ensure the survival of the graft. But the survival of the graft is pretty sure because we applied the graft above a periosteum area, and the periosteum is highly vascularized and will ensure enough vascular supply to our free gingival graft. The graft should be tightly adapted above the recipient bed through single interrupted suture in the most coronal aspect, external mattress suture in the mesial and distal apical aspect, and with this suture anchored around the suspended around the healing cap, that is able to compress the free gingival graft above the periosteum, avoid any blood clot formation too thick between the graft and the periosteum, because the only thing that we should avoid during the first healing period is a destabilization between the graft and the underlying periosteum, because we need to achieve a vascular anastomosis between the inner aspect of the graft and the periosteum as soon as possible to ensure the survival of the graft. The height of the graft is usually 5 mm because the final outcome, the ideal, is to obtain a 4 mm height band of stable, dense keratinized tissue. And if you compare the baseline and the 1 year post-op, you immediately understand how now it's different for the patient to brush this area. At the baseline, this implant was positioned in an area with only alveolar mucosa, and alveolar mucosa is mobile. And when the patient tried to brush this area, it was really discomfort. Now, with this 4 mm stable band of keratinized tissue, it's really easy to perform oral hygiene procedure, and so we can presume that the patient will be able to maintain an healthy peri-implant tissue for a long period, as you can see in this 7-year long-term result. When we speak about supracrestal soft tissue, when we speak about increased soft tissue thickness, we are speaking completely of a different field. We are speaking about these techniques that are able to create or recreate the so-called supracrestal soft tissues, meaning the tissues from the buccal bone crest to the mucosal margin. This area sometimes are lost in case of soft tissue deficiencies, for example, or in other case, we need to create an adequate dimension of supracrestal soft tissue when we place implant in the frontal area. And the idea of the supracrestal soft tissue and the thickness of the supracrestal soft tissues is to improve the final aesthetic result and to give a right emergence profile of the implant supported crown. And the importance of the thickness of the tissues in this transmucosal supracrestal area is related to the fact that I told you at the beginning that differently from teeth around implant, we don't have the connective tissue attachment, the real connective tissue attachment. So the only way we have to withstand and to reduce the risk from mucosal recession is to have a thicker soft tissue, thicker than 2 millimeters in order to withstand the inflammatory process that usually occupy 1.5 millimeters, because even in presence of plaque or traumatic toothbrushing, we will have 2 millimeters of connective tissue that will be able to withstand this area of inflammatory process and will not experience mucosal recession. And so the idea at the beginning was how we can solve this aesthetic failure, this implant with an aesthetic failure. And in this case, we start with these, let's say, easier cases. In this patient, we don't have a real soft tissue dehiscence in apical coronal dimension. But if you look on the occlusal pictures, you immediately understand that we have a bacolingual soft tissue deficiency. So in this case, we don't have the right emergence profile of the implant supported crown, and we can see by transparency the implant supported restoration, because the alveolar mucosa is very, very thin and cannot mask the transparency of the grayish material of the underlying metallic structure. So in this case, our surgical procedure was to reduce the crown and to reduce the abutment in order to let the interproximal soft tissue regrowth, and then we perform, when the tissues were mature at the level of the interproximal area, we perform a trapezoidal shape flap design, and we had mucoderm, which is collagen matrix that you can see can be simply trimmed and adapt of the right shape. It's a very easy material to handle and can be fixed at the base of the anatomic desepithelialized papilla, exactly as we did with a connective tissue graft, very easily. And in this case, you see the adaptation of the material above the prepared recipient bed, the complete closure of the collagen matrix is one of the most important aspects of this surgical procedure, because the matrix will act as a scaffold to incorporate the blood clot. And during the degradation of the collagen matrix, the blood clot will become new connective tissue and will increase the soft tissue thickness in the supracrestal soft tissue area, meaning from the buccal bone crest to the soft tissue margin. And this is the healing 2 weeks after, where you can see the stability of the coronally advanced flap and the complete covering of the collagen matrix. And this is the healing 6 months after. After 6 months, the collagen matrix, the mucoderm, is completely degraded. So the thickness that you can measure now, it's real connective tissue increase, is real soft tissue thickness increase. And if you look on the occlusal pictures, this is always the best view to understand how the thickness now are increased. And you can see that from the baseline where you can appreciate a concavity, now at 6 months you have a buccal convexity that improve a lot the emergence profile of the implant supported crown. And if you look at the quality of the aspect of the color of the soft tissue, you see how healthy are the transmucosal path, the tissue, the internal tissue from the head of the implant to the mucosal margin. And this is the stability of the results after 2 years with a nice emergence profile of the crown and a nice increase in soft tissue thickness that you can better appreciate in this occlusal picture. And this was one of the cases that we treated in this case series study, in which we demonstrate how it is possible to increase in a predictable way soft tissue thickness around positioned implant with the use of this collagen matrix. And this collagen matrix show a very interesting result and the capability to increase soft tissue thickness more than 1.5 millimeters, which is our final outcome. As I told you, we need to have more than 1.5 millimeter increase in soft tissue thickness in order to withstand the inflammatory process that can occur. Obviously, reducing the morbidity for the patient because we can use the collagen matrix instead of a connective tissue graft deriving from the palate. But let's look at this case. In this case, we have not only a baccalingual deficiency, but we have also an apical coronal deficiency. There is the mucosal margin at the level of the implant-supported crown, which is more apical with respect to the ideal position, which is the position of the gingival margin on the homologous natural tooth. The implant was well osseointegrated, so the problem was an aesthetic problem for the patient. So our surgical procedure in this case aims to recreate the supracrestal soft tissue dimension, meaning the right supracrestal soft tissue from the buccal bone crest to the mucosal margin and increase the thickness of this supracrestal soft tissue. So the first step of our procedure, which is the so-called combined prosthetic mucogingival procedure, is to remove the old crown, to reduce the abutment, and to place a short provisional crown in order to let the interproximal soft tissue regrowth and occupy the interproximal space in order to increase the quantity of vascular supply that we have for our coronally advanced flap. So you see the patient during the pre-surgical prosthetic phase with the short provisional crown in position. And you see the differences now that we have with respect to the baseline situation. If we want to position our connective tissue graft that will be covered with the coronal advanced flap at the level of the final ideal position of the mucosal margin, at the baseline, you see that we have only 2 small triangular anatomical papilla that will remain coronally with respect to the ideal position of the connective tissue graft. And these 2 small anatomical papilla will not give enough vascular supply for the surgical papilla of the coronally advanced flap. So with the prosthetic pre-surgical phase, we are able to increase a lot these interproximal soft tissues. And as I told you, the anatomic disepithelized papilla represent the heart of our surgical procedure because they give the vascular supply that will ensure the survival of our coronally advanced flap. So this pre-surgical step is of paramount importance to obtain a final optimal result. And this is the patient the day of the surgery. The shape of the flap is the trapezoidal shape flap design, meaning 2-3 millimeters horizontal incision and 2 vertical releasing incision slightly divergent that reach the alveolar mucosa. We need the vertical releasing incision to attain the right coronally advancement of the flap, because we can take advantage of the flap that we don't have a tooth in this case, because we can work, like you can see in the video, without the crown in place, and we can at the end of the surgery displace the anatomical papilla not only coronally but also coronally and toward the palatal aspect, taking advantages of the desepithelialization of the interproximal soft tissue also in the occlusal aspect toward the palatal aspect. And this increases a lot the vascular supply that we will give to the coronally advanced flap. The surgical procedure starts after the flap design with the split thickness surgical papilla elevation. Surgical papilla should be elevated split thickness, keeping the blade parallel to the external tissues, trying to elevate the papilla with a uniform thickness in the entire body of the papilla, not too much, and uniform as much as possible. At the level of the vertical releasing incision, as you can see, the blade is always bent, is always beveled. You don't have to touch with the blade perpendicular at the level of the vertical releasing incision, otherwise you will cut the periosteum and you will risk scar formation during healing. Then with the periosteum elevator, you can elevate full thickness the certain portion of the flap to increase as much as possible the thickness of the flap in this area that will be coronally advanced and will remain positioned above an avascular area. Then with the deep split thickness incision parallel to the bone, you start to detach the alveolar mucosa from the deep insertion. You see, this is the deep split thickness incision with the blade parallel to the bone. Once the alveolar mucosa is detached from the deep insertion, you can change, as you can see here, the angulation of the blade and use the blade parallel to the external mucosa. And in this way, you completely remove all muscle insertion from the alveolar mucosa. And this is the only way we have to release our flap, to obtain a flap without any tension, because it's free from all muscle insertion. And this is the desepithelialization. As you can see, the desepithelialization is performed not only on the vestibular aspect, but also on the occlusal aspect, increasing a lot the vascular supply that this desepithelialized anatomical papilla will give to the surgical papilla of the flap. And now it's time to harvest the connective tissue graft from the palate. Our harvesting technique of choice is always the free gingival graft technique, the same technique that we did 10 minutes ago for the treatment of the posterior area with the free gingival graft. But in this case, we remove the external layer of epithelium because we are performing a bilaminar technique. The harvesting technique is always the same because we demonstrate in a randomized controlled clinical trial that with this technique we are able to obtain the best quality of connective tissue graft made only of dense, immediately subepithelial connective tissue on the palatal aspect, not increasing the morbidity for the patient. We fix the connective tissue at the level of the ideal position of the gingival margin, 1 millimeter more coronal with respect to the ideal position of the gingival margin, with at the base of the anatomic desepithelialized papilla, and also with horizontal external mattress suture in the apical position, because we want to place the connective tissue graft also above the buccal bone crest. And then we start to close the flap. Flap closure always start at the level of the most apical extension of the vertical releasing incision to gradually reduce the tension for the last important suture, that are the sling suture, that are able to adapt the surgical papilla above the anatomical one. Usually around teeth, we suspend the suture around the tooth with the recession defect. In this case, we prefer to suspend the suture around the adjacent teeth, because when we close the knot, when we tighten the knot, we can shift the tension of the knot toward the bone peak of the adjacent teeth, like you can see exactly in this moment in the video. Then we did the same thing on the distal aspect, and to improve first intention wound healing, we can also perform some single interrupted suture to obtain better adaptation and a complete closure between the surgical papilla and the anatomic desepithelialized papilla, because we need to obtain a complete stability of the wound under the flap. As you can see, we cannot see any portion of the connective tissue graft exposed because the flap is advanced coronally, 1 millimeter more coronally with respect to the position of the connective tissue graft, and no bleeding either from the vertical releasing incision or to the occlusal aspect, and that ensure the stability of the blood clot, which is one of the key aspects of the healing of the mucogingival procedure. At the end of the surgical procedure, we place a short provisional restoration, which is not in touch with the soft tissue, because we have to wait for an undisturbed maturation period. The soft tissue maturation period will last 3 or 4 months, and then we can start with the soft tissue conditioning, so another prosthetic phase of this combined surgical procedure. And then is the time for the final reconstruction delivery. As you can see, the transmucosal area, that means the internal aspect of the soft tissue from the implant head to the mucosal margin, is now thick enough in order to prevent the risk of recession recurrence, because this thick tissue will withstand the inflammatory process that can occur for plaque accumulation or for traumatic tooth brushing. And this is the customized abutment for the final prosthetic restoration, and this is the nice final result after 1 year, where you can see complete dehiscence coverage. That means that the gingival margin at the level of the implant supported crown is now exactly at the same level of the gingival margin of the homologous natural tooth. And the soft tissue thickness that we are able to obtain in the supracrestal soft tissue area, meaning in the area of soft tissue from the buccal bone crest to the gingival margin, is thicker than 2 millimeters. As you can appreciate in the profile pictures, and the natural aspect of the soft tissue and the natural emergence of the crown from this healthy and thick peri-implant soft tissue that will ensure the stability of this nice result up to 5 years. And if you look at the profile pictures, you see that we can appreciate a further increase in the soft tissue thickness with time due to the harvesting technique that we perform, because as I told you, with the free gingival graft and desepithelialization, we obtain this dense layer of connective tissue graft that during the healing not only doesn't shrink, but with time is able sometime to further increase in soft tissue thickness. And you see, it's almost impossible to recognize the margin around the implant supported restoration and the adjacent teeth. And this was one of the cases that we treat in our case series study, in which we reported the outcome also after 5 years to demonstrate the stability of this combined prosthetic and mucogingival procedure in the treatment of soft tissue dehiscences. And the same concept that we apply for the treatment of soft tissue dehiscence, the same concept we apply in rebuild the right supracrestal soft tissue in height and thickness, should be applied also during implant placement. Because When we place an implant in the aesthetic area from premolar to premolar, we have to give the right emergence profile and we have to give the right aesthetic result to our patient. So if you look at this area where there is a first premolar that was removed for tooth reason, and if you look how is the gingival margin, you immediately realize that if we don't perform any soft tissue management before or during implant placement, we will not end with a nice aesthetic result because the implant supported crown will be longer than the adjacent natural premolar. So the idea in this case was to increase the soft tissue height and thickness. Implant placement should be performed in a guided way in order to plan the right position of the implant and of the implant restoration. And then we elevate a flap with the same flap design that we use when we treat multiple adjacent gingival recession, meaning oblique interdental incision directed toward the edentulous area in this case. Triangular shaped surgical papilla are elevated split thickness, and then we have to elevate the flap full thickness in order to expose the bone to place the implant. Implant placement, as I told you, will be performed guided. This is the deep split thickness incision in order to detach the alveolar mucosa from the periosteum, keeping the blade parallel to the bone. This deep incision should be performed because otherwise we cannot use the blade parallel to the alveolar mucosa like I'm doing in this moment. You see the blade is completely parallel to the alveolar mucosa, very, very superficial, because I'm detaching all muscle insertion from the alveolar mucosa. And you see now the flap can be coronally advanced. So the flap now is prepared. And with this kind of flap approach, we are also able to treat if present gingival recession affecting adjacent teeth. We place the guided and we remove the soft tissues in the occlusal aspect to place the implant. And this is the guided implant procedure. We already plan the right length of the implant, the right diameter of the implant, the right position, and this is of paramount importance because the main predisposing factor, the main etiological factor for soft tissue dehiscence occurrence around implants is related to the buccal implant position. If you place the implant in a guided way, you are sure of the implant positioning, so you reduce a lot the risk of dehiscence recurrence with time. Another important advantages of the guided implant procedure in this case is that you can prepare a provisional restoration that can be just realigned intraoperatively and placed in a very easy way. This is the desepithelialization of the anatomical papilla. You can see in this area, since it was a delayed implant placement, we have these two big and nice anatomical papilla that can be desepithelized. Since we want to create the right dimension and the right thickness of the supracrestal soft tissue, we want to place a graft that will be fixed at the base of the anatomic desepithelized papilla in order to obtain between the graft thickness and the flap thickness more than 2 millimeters of soft tissue thickness from the mucosal margin to the buccal bone crest, in order to have in the supracrestal soft tissue enough thickness to prevent gingival recession occurrence or to mask the transparency of the underlying abutment or implant. Because as you can see, when you place an implant, you need to have bone in the apical part. You need that the implant is well correctly positioned in enough bone. But when you have to give the aesthetic result, you need to have enough soft tissue in the supracrestal soft tissue area. Because from the buccal bone in the apical direction, it's a matter of bone. From the buccal bone to the soft tissue margin, it's a matter of soft tissue. And this soft tissue from the buccal bone to the gingival margin should be of at least 2 millimeters because they are not really attached like around teeth. And so if you want to withstand the inflammatory process, you need to have more thickness than the thickness you need around teeth. Once the graft is fixed and the anatomical papilla are desepithelialized, you can start to close the flap. The flap is closed through this suspended suture, and the provisional crown is in position and is of paramount importance because the provisional crown will support the soft tissue that are coronally advanced in order to give to the implant supported crown the right dimension. As you can see here, at the end of the surgery, after the implant placement, we have the soft tissue at the same level of the homologous premolar tooth. As you can see, the anatomical papilla in the pictures were desepithelialized not only on the buccal aspect but also on the occlusal aspect, and then the soft tissue will be tightly adapted around the convexity of the provisional crown. And this is 2 weeks after at suture removal. You see the stability of the flap in the coronal position because the connective tissue graft helped the stability of the flap in the final position. The provisional crown helped the stability of the soft tissue in the final position. And this is, from an occlusal point of view, the transmucosal path, healthy and thick. And this is the nice result where you can see also the treatment of the adjacent gingival recession and the right dimension of the implant supported crown at the level of the first premolar, which is also shorter than the adjacent one. And this is the comparison of the soft tissue height from baseline to final restoration, thanks to the coronally advanced flap and the adjunctive use of the connective tissue graft that increase soft tissue thickness to improve the emergence profile of the crown. And this is the stability of the result after 5 years, showing how predictable also in the long term are these procedures, because this is the 7 years outcome. Increase in soft tissue thickness that will ensure a right emergence profile and the right aesthetic. And what is different when you are placing an implant with a delayed approach or with an immediate approach? Basically, when you place implant immediately, you don't have the right dimension of the anatomical desepithelialized papilla. So the idea is to perform the same flap approach, the same guided implant placement. The only difference is that we will fix the connective tissue graft, not at the base of the anatomical papilla because they are not big enough, but we will fix the connective tissue graft in the inner portion of the flap 1 millimeter paramarginal with respect to the mucosal margin. So the only difference when you place an implant in a delay situation or immediately post-extraction, since you want to place the connective tissue exactly at the same level, which is 1 millimeter more coronal to the ideal position of the mucosal margin, you have simply to fix the graft at the inner aspect of your flap because you don't have enough dimension of the anatomic papilla when you are placing an immediate post-extraction implant. like in this case where there was this central incisor that was failing and that we decided to replace them immediately, because obviously that also from a patient point of view, the immediate implant restoration is the technique of choice. But we need to follow this step in order to avoid the risk of recession formation, which has been demonstrated also in literature, which is higher in the post extraction immediate implant. So we elevate the flap because we want to extract the tooth in a traumatic way for the soft tissue. And we open the flap also if we place the implants in a guided way, because we want exactly to see where is the buccal bone crest, and because we want to position our connective tissue graft 1 millimeter more coronal with respect to the ideal position. So we need to coronally advance our flap. So this is the guided implant placement after the tooth extraction, ample flap elevation, coronally advancement of the flap, and now we have our provisional that should be realigned intraoperatively, but it's very easy because we already prepare it before the surgery thanks to the planification of the implant placement, and we can feel the gap. If the gap is bigger than 1.5 millimeter between the implant and the buccal bone crest, we feel the gap with the biomaterial. In this case, we use Cerabone, and we measure the distal dimension of the connective tissue graft that we need, and we go on the palatal aspect. The thickness of this connective tissue graft should be enough to obtain with the flap 2 millimeters of thickness at the end of the surgery. So usually the flap is thin, so usually we need to harvest 1.3, 1.5 millimeter thickness of connective tissue graft. That, as you can see, will be fixed with this internal mattress suture 1 millimeter more paramarginal with respect to the gingival margin, apical with respect to the surgical papilla, because the surgical papilla should remain free to be tightly adapted above the anatomic disepithelialized one with the suspended suture to obtain a tight and nice adaptation of the mucosal margin around the provisional restoration. And this is the nice final result in this surgical procedure that combine the coronally advancement flap with a connective tissue graft simultaneously to implant placement. We are able to create the right supracrestal soft tissue in both height and thickness, and these ensure a nice aesthetic result for our patient. But this is even more challenging, because in this case we don't have not only the problem of the mucosal recession on the buccal aspect, but we have also the interproximal soft tissue that are lacking. So in this case, the goal of our surgical technique is to recreate 365 degrees the supracrestal soft tissue, to recreate the supracrestal soft tissue not only on the vestibular aspect, but also at the level of the interproximal soft tissues. So the only way to surgically overcome the lack of the interproximal soft tissue thickness is to treat the area as if it was an edentulous area and perform the so-called platform technique. That was a technique that we propose in literature for the treatment of the edentulous area, in which we want to increase soft tissue thickness to improve the final aesthetic result in a traditional restoration. So in this case, we perform exactly the same surgical technique removing the abutment, placing a kneeling cap, and treating this area exactly as if it was an edentulous area. So we submerge the implant. We submerge the implant and we place connective tissue graft above the platform area, the connective tissue platform area in the occlusal aspect and on the buccal aspect in order to increase the quantity of the soft tissue, both in coronal and in buccal aspect. And then we completely cover it with the coronally advanced flap, completely submerging this connective tissue graft to be able to three-dimensionally rebuild the soft tissue. And at the end of the surgery, we place a Maryland bridge provisional restoration, which is not in contact with the soft tissue. And then we can start, after the undisturbed healing, with the conditioning phase of the soft tissues. And this is the final result after the conditioning phase with the final restoration in place. So you can see in an occlusal pictures the thickness of the transmucosal area, which is more than 2 millimeters and which is longer because we should compensate for the malposition of the implant, and we need to obtain the mucosal margin at the same level of the homologous central incisor. But if you look at the quality of the color of the tissues in the transmucosal path, you see how healthy these tissues are. Obviously, this patient was a very highly motivated patient, non-smoker with a good oral hygiene level, and all these aspects, along with the surgical procedure, lead to obtain at 1 year this nice result. You can see the emergence profile of the crown, and if you look at the superimposition of the initial baseline situation with the follow-up, you can appreciate the increase in the soft tissue thickness, not only in apical coronal dimension on the buccal aspect, but also at the level of the interproximal soft tissue, where you can see that also the class 4 Miller recession defect at the level of the lateral incisor was completely covered due to this technique that is able to increase the soft tissues like we did in an edentulous area. And this is the stability of the result after 2 years, and with the X-ray showing also the stability of the bone level and the transmucosal pairs healthy and nice. And so basically we have two kinds of technique: the keratinized, the technique that aims to increase the keratinized tissue thickness, height from one side, and the technique that aims to create or recreate the supracrestal soft tissue. The keratinized tissue is a characteristic, is an external feature of the soft tissues. And the technique of choice to increase the quantity of keratinized tissue in height is the free gingival graft, which is suggested in the posterior area due to the keloid aspect of the free gingival graft healing. And the aim of this technique is to improve plaque control in the posterior area. While the technique that aim to change the supracrestal soft tissue are indicated to create soft tissue, supracrestal soft tissue of the right thickness when we place implant, or to recreate, as in case of soft tissue dehiscence treatment, the right quantity in height and thickness of the supracrestal soft tissue. And this technique is indicated in the aesthetic area and should be performed with the aim to improve the aesthetic for the patient and to improve the right emergence profile of the implant supported crown, and is always done with a coronally advanced flap with a connective tissue graft, or in cases where you have only to increase the soft tissue thickness because you don't have a real apical coronal soft tissue dehiscence, you can also use, instead of a connective tissue graft, a collagen matrix. And with that, I thank you very much for your attention, and I'm waiting for your questions. Thank you. Okay, so I hope you enjoy the webinar, and I can see a lot of questions, and I already apologize for the question that I will not able to answer because they are really too much, but it's such a positive feedback for me, so I'm very happy, and I will start immediately to answer your question. The first question that I would like to address is regarding the keratinized tissue augmentation technique. Some of you ask me what would happen if the value would change instead of 1.5 millimeter thickness of the free gingival graft. The reason why I have to harvest 1.5 millimeter thickness of free gingival graft is because I need to ensure enough thickness to the graft, to the free gingival graft, that will remain completely exposed to survive. So it needs to be thick enough. If I will harvest less than 1.5 millimeter, let's say only 0.8 millimeter thickness of free gingival graft, it will be not thick enough, it will shrink. And also when you harvest 1.5 millimeter, most of the time it shrinks a little bit, but it remains stable. So more than 1.5 it's okay, but less than 1.5 is not enough. And the reason is to ensure the survival of the free gingival graft that will remain exposed to the oral cavity, will not be covered as the connective tissue graft in the bilaminar technique. And what is soft tissue dehiscence? The definition of soft tissue dehiscence is an apical position of the mucosal margin of the implant supported crown with respect to the ideal position. Which is the ideal position? This is the problem, because when we speak about gingival recession around teeth, we have a reference point, stable and fixed, which is represented by the cemento-enamel junction. When we speak about implant, it's very difficult to find a fixed reference point which is the same in all implant supported crown. So basically we decided to establish that the ideal position, the reference point, is the ideal position of the gingival margin of the homologous lateral tooth. So you have to take into consideration the gingival margin of the adjacent tooth in the healthy position. That means 1 millimeter more coronal with respect to the cemento-enamel junction, because the final outcome of your treatment when you are treating a soft tissue dehiscence is to obtain a nice aesthetic result from a patient point of view. And what does it mean? That means to have the same dimension of the implant support and crown length with respect to the adjacent teeth. And do you raise a full thickness flap before placement of mucoderm? What is the name of the collagen matrix? Exactly, I can answer both questions. The collagen matrix that I was using in the case that I shown, and that was one of the cases included in our case series, is the mucoderm from Botis, from Straumann. And yes, I elevate the flap in the same way. Split thickness at the level of the surgical papilla, full thickness in the central portion, and then more apically again, full deep split thickness incision and superficial incision to obtain the release of the flap. The rationale behind the full thickness elevation in the central portion of the flap is to obtain a flap which is as thick as possible in the central portion, that will be moved coronally and will be positioned above an avascular area. This idea comes from mucogingival surgery around teeth. When I coronally advance a flap to treat a gingival recession around teeth, I always elevate full thickness, inserting the periosteum elevator inside the sulcus, and I elevate full thickness the flap up to 3 millimeters on the buccal bone crest, because this central portion of the flap will be coronally advanced and will cover the avascular root area, while the surgical papilla will be positioned above the anatomic desepithelialized one, and they will receive vascular supply for them, while the central portion of the flap will not receive any vascular supply from the underlying tissue because he's hard and avascular in both treatment, teeth and dental implants. So the rationale behind the full thickness elevation in the central portion, when it's possible, that is mean that you need to have some small amount of keratinized tissue remaining apical to your soft tissue dehiscencies or your gingival recession, but when it's possible, I always use the periosteum elevator for 3-4 millimeter in the central portion. And if we see the collagen matrix with cells that possess the ability to keratinize, I don't know, I don't have any experience in the adjunctive use of live cells, and so I cannot give you an answer according to my experience. What I want to tell you is that in the frontal area, I'm not really interested in gain more keratinized tissue. As I told you, keratinized tissue is something that I would like to obtain in the posterior area, and it's not a matter of quality, but it's a matter of tissue which is stable. Because it's adherent to the underlying periosteum and improve the capability of the patient to brush in this area. In the frontal area, the quantity of keratinized tissue, the height of the keratinized tissue, is in relation to the mucogingival line position of the patient. And with time, after the coronal advancement of the flap, I will have a repositioning of the displaced mucogingival line, and I will have, with time, an increase in keratinized tissue. How much? How many keratinized tissue was genetically predetermined for this patient in relation to the height of the mucogingival line on the adjacent teeth. And for how many days is the narrow provisional abutment in place to let the interproximal tissues grow? Yes, in the combined prosthetic surgical approach, the pre-surgical phase consists on removal of the old crown, narrowing the underlying abutment or changing with a narrower one, and place a short provisional crown. Usually it takes from 1 to 2 months, this period. It depends from patient to patient, but usually it takes between 1 and 2 months. And how long did you keep the short temporary crown? Before the surgery, the short temporary crown will last for 1-2 months up to the day of the surgery. Then after the surgery, I have to shortening the temporary crown because I want to cement it immediately after the surgery without avoiding any contact with the soft tissue. And this will last for, let's say, at least 3-4 months before starting the conditioning phase. I know it's a very long story. This combined prosthetic surgical approach, it's a very long procedure. It takes time, but it's something that is the only solution in certain cases instead of implant removal to give back the possibility to smile to our patient. So it's a decision that you have to take with your patient. If the patient wants to have an aesthetic result, they have to perform all these steps, and it takes time. Are the vertical incisions split thickness or full thickness? Does one reduce the risk of scarring? The vertical releasing incision are always performed split thickness with the blade beveled. You never touch the periosteum perpendicular to the bone like this. Also, when you perform the so-called flap design, you are simply creating a bleeding line with the tip of your blade that is not touching the underlying bone, because you don't have to cut the periosteum. Otherwise, you will experience scar formation during the healing, for sure. Desepithelialization, yes, desepithelialization means to remove the epithelium layer from the anatomical papilla. We have two kinds of desepithelialization. One desepithelialization is the desepithelialization of the anatomical papilla. You have to remove the thin layer of epithelium on the vestibular and on the occlusal aspect when you are treating dehiscencies around implant in order to expose the connective tissue underlying that will create the anastomosis with the connective tissue in the inner aspect of the surgical papilla. In this way, surgical papilla above desepithelialized anatomical papilla will have anastomosis, an exchange of vascular supply, and this will ensure the survival and the stability of the coronally advanced flap. The other type of desepithelialization is the desepithelialization of the free gingival graft to obtain a connective tissue graft. I know there are other questions regarding the harvesting technique. My harvesting technique of choice is the free gingival graft because with this technique I'm able to harvest the best quality of connective tissue, because you know that the deeper you go into the palatal aspect, the more fatty and glandular tissue you will harvest. So if you have to perform a trapdoor technique or L-in-C or HELT technique or envelope technique, you have to elevate the flap and then remove the remaining connective tissue graft. And in most of cases, you don't have enough thickness. And if you don't have enough thickness of connective tissue, you harvest fatty and glandular tissue. And fatty and glandular tissue during the healing will shrink. So in my hand, I always prefer to perform the free gingival graft, and then I will desepithelize the free gingival graft. What does it mean? I remove as uniformly as possible the thin layer of epithelium. And when I'm treating soft tissue dehiscencies, since I want to increase soft tissue thickness more than 2 millimeters, I need to have, after the desepithelialization, a connective tissue graft thick enough to obtain, with the thickness of the flap, 2 millimeters of thickness. And some of the last question regarding the suture. Suture material is the PGA. I always use PGA, resorbable suture, for the free gingival graft, for the bilaminar technique, for the flap, for every mucogingival procedure. I love this suture material because it's soft. It's quite resistant, so you can use in very, very thin suture. I mostly use 6-0 and 7-0, so very, very thin. So it's a quite resistant suture material, but on the other side is soft. So when I tighten my suture, the risk is not to tear the tissues, but in case I tighten too much, I break the suture, which is less problem than damage the tissues. Why I don't perform tunnel technique? I don't perform tunnel technique because with the tunnel technique, you are not able to see exactly the bone crest, so you don't know if the height of your connective tissue graft is positioned above the buccal bone crest. You cannot coronally advance the flap enough. Also, if you perform the modified tunnel technique without vertical raising incision, you are not able to coronally advance it, completely cover the graft in the final position, and obtain an increase, a vertical increase in the position of the mucosal margin. So if I need to cover a soft tissue dehiscence in an apical coronal dimension, I cannot coronally advance a flap. Probably if I have just to increase the thickness, like in the case I show you with the mucoderm, you can also perform a tunnel, place the mucoderm and close your tunnel. But if you have to treat an apical coronal soft tissue dehiscence, you have to coronally advance the flap. And the same concept when you apply, when you place an implant. My dear friends, my dear colleague, our time is finished. I'm really happy to have the chance to share my presentation with you and to answer to this question. You are really great, curious, and So I hope to have the chance to meet you in the future personally to answer your question personally. So take care, stay safe, and see you somewhere in the world in the future. Bye.